Happy Saturday, everyone. I'm Judy Thompson, AVA's Director of Clinical Education, and I'm excited to be here with you on our third day of AVA 2021 virtual. I hope you have your coffee in hand, filled up, and ready for our first session today. Do Needleless Connector Manufacturer Claims on Bi-directional Flow and Reflux Equate to in vitro qualification of fluid movement. That's a mouthful. Using scientific data to drive best practice. Our kickoff speaker today is Matt Gibson. Please refer to the conference website for the full backgrounds of our speakers today. Now, Matt likes to refer to himself as just a good old boy from Kentucky, but you'll soon hear there's much more to this talented speaker than just Kentucky. Matt, take it away.
Thank you, Judy. Man, it's awful early out there for you guys, isn't it? Woo! I believe you've been up since what, 3 a.m.? So we hope that the West Coast is joining us because it's definitely early. So, well, good morning, everybody. And man, what a fantastic conference we've had so far. And I want to get straight to it. This subject matter, needleless connectors, has been a decade of learning for me. And it led me to this project, and I hope I bring some clarity where you may not even know you're confused, because believe me, I stay confused a lot. So the more clarity I have, the better off I am. Just a little bit about me. I am a vascular access clinician that is currently placing lines. But I do also have a consulting business, and I work for a lot of different people as far as consulting, help writing education, teaching vascular access. Here's all my disclosures, and I feel very fortunate to be able to work with so many different people to advance the practice of vascular access. It's really exciting for me. It's something I never even imagined that I could do. So today, what we're going to talk about, I'm going to bring in the prevalence of thrombotic catheter occlusions and the clinical significance of that as it relates to needleless connectors. My objective here is hopefully you'll understand all about needleless connectors and when and how much they reflux. I'm going to go into some detail about the categories, because this has been a real struggle for me over the last decade. A lot of confusion around terminology and how these connectors work and what we're supposed to do with these things. And I want to really go into more detail about how to prevent the complications from blood reflux in vascular access devices. So that's what this whole project is about. But first, I think we need to really very simply define what patency is and occlusions. Patency, you'll find these in the standards of practice. Patency is simply the ability to flush the catheters and yield blood return. And that blood return is not just like a little spit of blood in there, a little hinge of blood. It's the color and consistency of whole blood. And occlusion is just the opposite. It is, preventing or limiting the flush. So it's sluggish. This is a common thing that we call it, sluggish flow, or withdrawal occlusion. So, you can flush it easily, but you can't draw blood out of it. And when we look at the different types of occlusions, there's something different going on at the end of that catheter. If you have a complete occlusion, you can't flush it, you can't draw blood out of it. It's completely occluded. And we certainly are going to have to do something with that catheter. Partial occlusions can be sluggish flush or sluggish withdrawal of blood. And you're like, man, this is tight. This is sluggish. This isn't acting right. Withdrawal occlusions is very common. It's simply, you can flush it very easily, but when you pull back, you can't get blood return. And for each one of these types of occlusions, there's something a little bit different that's going on. So here's all the signs and symptoms. It's sluggish, You can't flush it. Maybe the pump's going off. It could be that the site is leaking, at the infusion site. It could be some type of mechanical occlusion. It could be kinking, and it could be intermittent, like, hey, it's positional. And then it could be thrombotic, or it could be a precipitate, which I don't have up here. So what's the prevalence of catheter occlusion? How does it really impact? It's just one of those things that happens, right? Just a complication. It's just going to happen. I wonder sometimes if it's more of what we're doing to these catheters that could be contributing to these occlusions. But catheter occlusion is one of the most common complications we have, from 12 to 36% for central lines. And then when we look at the peripheral IV, when we look at Helm's article, which, by the way, I was like, my heart was fluttering with Dr. Robert Helm yesterday. I was just like in awe. Fantastic. I'm so glad that he's joined the speakers of AVA. But in peripheral IVs, there is a significant amount of failure due to occlusions. Now, this is all encompassing. It could be mechanical occlusions, could be thrombotic occlusions, and all of that is encompassing. Whenever he did his huge review, and if you haven't read this article, and I'm sure there's some people out there that haven't read this, unacceptable but accepted PIV failure. It's in the INS journal. Dr. Robert Helm, please go out and get this article and read it. It has changed the way I view peripheral vascular access. So occlusions are not just catheter failures, but it also can affect other complications like infection. What do we do when our central lines get occluded? When they're sluggish, when they're 100% occluded, if there's a partial occlusion, if there's a withdrawal occlusions for central lines, listen, we need to have blood return every lumen every time. That's our standard. And so when they get sluggish and they get, we have a withdrawal occlusion, or you can't flush the thing at all, you got to do something about it. And what the most common thing that we do is we declot it. There's different protocols. Sometimes if you can't flush the catheter, you're going to check an X-ray, see where the tip is. Maybe it's curled up back on itself. Many times I've done an X-ray of the arm and have found that there's a kinking and occlusion in the arm. But these, if we rule out all of the mechanical occlusions, the next thing we're assuming it is a thrombotic occlusion, an internal clot that is blocking off or restricting the flow inside that. Well, what we found, there's two great studies, and I've got them listed here. But the risk factor of declotting is, close to, 3 to 3.5 times the risk of infection when you declot these catheters. It really you really start to wonder, okay, what are we doing here? We've just, these catheters just get clotted off. But is there something else is there something we're doing that is contributing to this? Because care and maintenance, we're not flushing it well enough, maybe, we're drawing blood frequently, not getting enough flush to flush all that out. That could be part of the problem. But the effect is that it is going to increase cost, delays in treatment. We've got a lot of problems with that, And from Dr. Chopra's article that came out last year, 21% of occluded PICs specifically were removed because they were occluded. That's a lot of work. That's a lot of extra work. In these times where we have, we're just going nuts from dusk till dawn, we need to we need to try not to have these occlusions. This is something that is, as part of advancing vascular access, is eliminating complications. And when we think of the cost, not only in patient delays and whatnot, but just the simple cost of declotting, and this is a cost model. If you're using a alteplase 2 milligram dose, here is kind of the breakdown. It's estimated it's going to cost for one dose of Cathlo, just the medication and getting it ready, about close to $145. And then the time that it takes the nurse to go do it, we got to gather supplies, we got to get the drug ready, got to go give it, and some of these are fairly easy to do, and some of them you got to work at it, so just on a hospital, around 300 to 400 beds, potentially, realistically, may have 50 declots a month. And when you multiply all that out, it could equal close to or more, and that's just one dose of Cathlo, $100,000. How many, how much work or how much labor, we could add a whole nother nurse, to our team, just to manage occlusions, to prevent that type of thing. So it's a significant problem, and it causes catheter malfunction, inability to use the device. We're having delays in the tests and the treatment. My buddy Joe Bunch was talking about having occlusions on a cancer patient where yesterday, and she had multiple serial occlusions on her catheter, and it caused a great deal of anxiety and a fear of the loss of her vascular access. And if it's 100% occluded and we can't get the thing declotted, we got to take the thing out, and we got to put another one in. And then when you dump on the whole risk of infection, we have some serious considerations. This is something that I have really started to consider as a major problem in vascular access. And Dr. Chopra says it very well. He says, identify risk of catheter occlusions, prevent such events, and not only is this going to help reduce the cost, but it could substantially improve patient safety. So eliminating repeat insertions, the risk of infection with the declotting, so I hope this information will help us not to be so complacent about occlusions. Oh yeah, that thing's occluded down there. I got to go down there and see if I can get it fixed. Go down there and get it going. That's I'd like to emphasize more of, hey, let's prevent these complications from happening. So I want to get into the weeds, so to speak, here just a little bit. On thrombotic occlusions. There is fibrin that we have that just attracts to these catheters like crazy. It can create a fibrin tail. This is like your one-way valve, so it flushes easily, but when you draw back on it, the little tail kind of folds down over the end of the catheter and doesn't allow you to draw blood. You can get a whole fibrin sleeve that's like a sock that encompasses that whole catheter. And we have seen this in especially long-term catheters where this sock and this sleeve will encompass that whole catheter and attach to the insertion site. And so when you're giving, say, a vesicant like a chemo, it goes down the PICC, into the sock or the sleeve, travels back up the outside of the PICC on the inside of the sleeve and out the insertion site, the exit site of that catheter, and causes an infiltration, which can lead to some really severe extravasations depending on the medication you're giving. And then we have a mural thrombus. So this is inside the vein, and it just encompasses the end of that catheter and blocks it off. And something that happens with occlusions is that if you can imagine dipping a candle in wax. So you're making this candle, and every time you dip it in, more wax forms on the outside of that candle. This is very similar to what happens with the blood that is exposed to the catheter. Every time we get blood inside that catheter, more proteins stick, more fibrin. It picks up platelets. The platelets are gonna pick up some RBCs, and it just starts to build and build. So it doesn't ever get better. It just only layers, in the inside of that catheter. And something that one thing that is kind of a clue for care and maintenance is if you have visible blood inside the catheter tubing that you can't flush out. This patient probably has a lot of sticky blood. Maybe the care and maintenance has been very poor, and we have not done a good job of flushing it. So it's just something that and if you go out and you look at your catheters, you're going to find this. You're going to find blood that's sticking on the inside of the catheters, and especially the needleless connector. Here's a great picture that I pulled off of one of the Altaplace manufacturer's website. It shows this fibrin tail. And you can see how the catheter itself flushes, it's going to flush very easily. There's nothing around that but this little tail. When you pull back, it's going to suck right over the end of that catheter and give you some problems. With a central line, we shouldn't be using it if we have this scenario. But this can happen on peripherals as well, and midlines, and ports, and any other kind of vascular access device. So this is just an animation. I love this, and I'm imagining I'm a catheter inside this vein, and this blood is starting to stick. And every time I get blood inside that catheter, it sticks a little more, a little more, a little more. And then eventually what you're going to see is that this clot starts to become bigger and bigger and bigger, and eventually will clot off your whole catheter. Now, have you ever gone to a peripheral IV and you think, oh, man, there's a little resistance here. This thing needs to be flushed. Like it's got some buildup in there, and we need to get this cleaned out. And it's a little bit sluggish, so to speak. And then you flush it, and then you go, oh yeah, this is fine now. This is perfectly fine. Well, this is maybe what's happening to this catheter, this peripheral. And honestly, it doesn't take a lot of force to do this. Now, if you didn't just go, ooh, then you're not watching this video. Like, this was a catheter that we put blood in and let it sit for 4 hours, which is maybe a common time. If you're only flushing, you've got a once a day antibiotic and you're flushing 8 hours. This is a common interval that you might see that this device wouldn't be touched. If the blood is backed up into that catheter lumen, you go to flush it, because with peripheral especially, it's hard to get blood returns out of these things, and people just don't worry about getting blood return out of it. They just use them. As long as it's flushing, it's fine. It's fine. Well, my question is how many times do we do this? And we inject this worm-like thrombosis straight out of that peripheral catheter into the bloodstream. This, I don't necessarily think that this is a big enough catheter that's going to, cause a pulmonary embolism and you're going to die. But what about the bacteria that might be growing in that? And we just shot it right into the bloodstream, you know? I mean, it just can't be good. It just can't be good. Here's an example of a central line that has one of those fibrin sheath that we were talking about, or fibrin sleeve, some folks call it. You know, I call it a sock because it just encompasses all of the catheter. If you look at the picture in where the white arrow is, that's the catheter tip. There's dye that's being injected into this vein. And look at what is happening all the way down, where if you look on the right side of the picture, it says fibrin sheath and it's got a little white bracket. That is the sheath that this dye is being injected through, and it's coming out at the bottom, towards the bottom of the screen. This just, it really puts it in perspective for me. Like, this is real. You know, and what on earth happens to that fibrin sheath when we pull that catheter out? Like, holy mackerel. But you can see why this might create an occlusion. What do the words mean? You know, sometimes my simpleton, country boy mind has trouble with big words. And you look at words and I like to read definitions because it definitely helps me understand. And this is a definition of needleless connector: a device that allows the connection of the luer tip of a syringe or administration set to a vascular access device, so that basically you can use it to inject medication. It's a closed system with no needles. So if you didn't know what a needleless connector is, now you do. I've got a poll here. We're going to put the poll up. So what we'd like for you to do is go to your text message. You're going to enter 22333, and then after you enter that code, I want you to answer this question. Do needleless connectors that are labeled as neutral reflux blood? So what I'm asking here is, how many people understand about neutral connectors? So, do connectors that are labeled as neutral reflux blood? Yes or no? You have the numbers here. You can just start enter that number. Oh, I love this. Oh, we got a split. Yes? No? 50-50. We'll give this a few more minutes. So both of the people that are listening to my my lecture this morning. Oh, we got some more people. Okay. Here we go. You know what? I believe some people have read my article. This actually surprises me, to be honest with you. Some of the smartest people I know over the last 5 years that I've talked to about this, definitely have not understood. And honestly, 10 years ago, I did not understand this either. I did not understand it well. So 80% of the folks that are online right now with me believe that neutral reflux blood. And that is the correct answer. Yes. Neutral connectors do, in fact, reflux blood. And this is something that has been a real struggle for me because, about 10 years ago, I was told. Now, I have to tell you the story. So the story is, I didn't, the first 20 years of my career, the first part, we were still using needles. We weren't even using needleless connectors. They weren't around. And then we went to alligator clips. Then we went to this needleless connector. And we knew that we had some increased problems, some increased occlusions, and what we found is, that it was the needleless connector. And so the manufacturers started trying to improve upon the first designs, and they came out with a different design, and then they came out with a different design, and when they came out with neutral, now I was told, hey, neutrals, you don't have to worry about clamping because they don't reflux blood. And this was my understanding for many years. And so I want to take you through the journey of needleless connectors from where it started and where I believe some of this confusion has come. Because fortunately, I'm kind of preaching to the choir here, and you guys are educated folks. The majority of the people don't understand, that neutral connectors reflux blood. So currently, in the 2021 standards, they tell us a few things about needleless connectors. All needleless connectors allow some fluid movement and blood reflux. This is a much different statement than what was in the 2011 standards of practice. It even brings up bidirectional flow that occurs, and it says basically there's bidirectional flow that occurs within the device, so fluid can move in and blood can move out. It acknowledges that there is a variety of mechanisms that are in designs. The categories are still listed as negative, positive, neutral, and anti-reflux. And so, where I have found kind of a hang up, a problem, is there's no real established criteria, for the devices. What is really, how much reflux does a neutral connector allowed to have? By definition, it's really not. There's not, a neutral connector doesn't have reflux. As you look at these diagrams, these are diagrams that address positive displacement, negative displacement, and anti-reflux. And it gives you the path flow. So the red is the path flow. The positive connectors, all positive connectors are going to have a little bit of flush that flushes out on disconnection, and this is how they do it. They have this elastomer polymer that kind of plug that's inside, and when it's released, then it pushes the fluid out and it clears the tip of the catheter. The negative displacement, upon connection, that's when you are going to get reflux. And it shows here in this diagram the fluid path, the red line straight through. Also with the anti-reflux, the fluid path is straight through. But where is the diagram of the neutral connectors? There's not one there, and I'll explain why. So here are the current definitions of the different types of needleless connectors. Neutral contains an internal mechanism designed to reduce blood reflux upon connection and disconnection. Okay, so we're going to have to talk about this a little bit more, but currently this is how it's defined. Anti-reflux, it is a connector that contains a silicone valve that opens and closes based on infusion pressure. And they, in the current standards, say these specifically have no clamping sequence that's required. The negative displacement, this allows blood reflux on disconnection. This is 100% true. Positive displacement, the definition, allows blood reflux on connection and disconnection. Okay, so here the words in red are part of issues that I have found. The positive displacement goes on to say that the small amount of fluid is held inside and it pushes out. and it does require a specific clamping sequence. So you're going to flush, disconnect, and then clamp. So negative and positive are relatively simple. With a negative displacement connector, you disconnect, you clamp before you disconnect. With a positive displacement, you clamp after you disconnect. But we got some blurred lines, in my opinion, with the neutral and anti-reflux. So I'm going to take you through this journey that I've been through over the last 10 years. And we're going to look at how the terminology has changed over the years, and why I think we're in the situation that we're in with some of the confusion about these connectors. These are all listed at the end, and you guys can certainly look these up. So in 2011, the neutral, look at the terminology, neutral connector is a needleless connector with an internal mechanism designed to prevent blood reflux. Okay, this to me is really, really significant. And it also states upon connection and disconnection. There's definitely a little bit of confusion about this. And I'm going to explain to you why in just a few minutes. Negative displacement is blood reflux that happens upon disconnection, which we can, or when the fluid container empties and remains connected. So, your bag runs dry and your blood backs up in the tubing. That, we've all seen that. Positive displacement, again, this is where we first see this in 2011. It has a little bit of fluid that pushes out when you disconnect. Okay, there's nothing mentioned here about positive displacement when the bag runs dry. But unfortunately, it's the same thing. If you have a positive displacement, when the bag runs dry, it's going to do the same thing as a negative displacement. So in 2011, Lynn Hadaway, and congratulations, well-deserved Herbst award this year, Lynn. It's past due. She did a study that surveyed different. This isn't the one. I'm sorry. Oh, yeah, this was a survey that she surveyed several nurses, a bunch of nurses actually. And what she found was that, a little over 14% did not understand the correct, it was only 14% that responded correctly for the clamping sequence for the negative displacement. So basically, there was, almost 85% of the people did not know how to clamp correctly a negative displacement connector. With the positive displacement, there was only 20% that understood how to do this correctly. And this was the statement. This was one of the statements from Lynn's article. Clamping sequence will not affect the functionality of a neutral displacement device. This is 100% correct. If you have a device, a needleless connector that has neither any type of reflux on connection or disconnection, the clamping sequence does not affect the functionality. But here we have a label of neutral, and it's very clear. And what has happened, and as we progress through this, we're going to see, where this has gone awry just a little bit. So, 65% of the people that she surveyed or 65% of the people used the same needleless connector throughout the entire facility. So that left a large number of people that were using different types of connectors. And, if they were using a negative and a positive displacement, the clamping sequence was completely opposite. And these were not, nursing students. These were people that were highly experienced with a great deal of knowledge that that should have really known. So as we've progressed, Hadaway wrote another article talking about needleless connectors, and again, reflux on connection. The for negative displacement, positive, the same thing. We're consistent. Neutral fluid displacement prevents blood from moving into the catheter lumen upon connection or disconnection. Again, this is 100% accurate. And what we've done with this terminology is where I believe we've gone awry. And as we progress through the anti-reflux, this is where we've introduced the idea of this silicone disc or diaphragm that helps prevent blood return. And this is the anti-reflux technology, and we first hear about it in 2012. And you can see the diagrams that Lynn provided. Fluid path, the mechanism of action, talks about the silicone disc with the slit in it, which has become known as the anti-reflux. But we just don't have much on neutral. There was no diagram and description of neutral. Again, in 2000, so in this period of time, this is when I went to bat. I found that neutral was the connector we wanted for our hospital. And so went to practice council, went to value analysis, says this is it. This is what we need. We need this neutral connector because it doesn't reflux. It prevents reflux. And this was what I was told, by the representation from the company. This is, doesn't reflux. It doesn't matter if you clamp it or not because it doesn't reflux blood. Fantastic. And in 2016, we have neutral needleless connector, again, that contains an internal mechanism device that prevents blood reflux. The definitions, of negative and positive are consistent. And then the anti-reflux, we have an official definition of what anti-reflux. Now, when you look at these two definitions, neutral needleless connector, internal mechanism designed to prevent reflux, and anti-reflux designed to prevent blood reflux. And I'm scratching my head and I'm like, isn't that the same definition? Like, I don't understand. This is where I start to become a little bit confused because why do we have anti-reflux connectors if neutrals is doing the same job? Shouldn't neutral mean no reflux? And how do we, quantify these definitions, of positive, negative, and neutral? Neutral is really the point that I started to investigate with this study that I did. How much reflux really equals neutral? It should be zero, and really there's no regulatory body. And this is, again, where we've gotten in some trouble with the definitions and understanding. What it boils down to is it's what the manufacturers have called their device. Negative, positive, neutral, anti-reflux. I'm frozen. Let's see. Here we go. Okay. So in 2017, you guys, this is what really affected me. Like, it affected me. Out of the University of Missouri, a fellow by the name of Hull did a quantitative study of all the needleless connectors available. And I read this article and I went, wait a minute. Here's the neutral connector that I am using, and this is what they say that it's refluxing. I'm like, wait a minute, this connector, it does matter. Like, I don't understand what is going on here, because my understanding and in the standards and what I've been told, neutral displacement connectors don't reflux blood. Clearly, there are 4 connectors that are labeled neutral on this study that do, in fact, reflux blood. Listen, guys, I'm telling you what, I thought my head was going to pop off. Like, I'm like, I don't understand what is going on here, because it is clear by definition that neutral does not need clamping sequence. It does not reflux blood, but yet we have a study here that shows they do. They do, in fact. I didn't believe it. I'm like, this is a bunch of bunk. Like, this drove me insane. It was not a far drive, and it drove me to do this study myself. And so I did the study, and I tested these connectors. Before I did that, I did some research, and I found a couple more articles that illustrated different reflux. And what I found is that, I as the labeled, and I pulled this from IFU's labeling, from the whole article, and from one of Lynn's articles. And these particular Needleless connectors were labeled as negative and what we found is, on disconnection, these are the amount of reflux that occurred, which totally made sense, because you do clamp, a negative needleless connector before you disconnect, so you won't reflux. But what I didn't understand, and this is something else I saw in the whole article, is that positive displacement connectors actually reflux blood. I'm like, what is going on? Like, how these things are not supposed to reflux blood, because when you disconnect it, it pushes the fluid out. Well, what happens is it refluxes when you connect it. This whole displacement thing, it's a give and take. Pretty much, if you have reflux, you're going to have some positive displacement. It's the way these connectors are designed, and so as I go through this further and further, I look at the anti-reflux connectors. There's 3 that I found, and they actually reflux blood. Now, significantly less, the incrementally, it is certainly less, but they still do actually technically reflux blood. And then we got to the neutral. OMG. These are connectors that, by definition, are designed to prevent blood reflux, and on disconnection, and should not require any type of clamping sequence. But in fact, these connectors reflux on disconnection as well. And you see some of the numbers, and certainly, overall, this is the design of the neutral. It's kind of like the 3rd generation of connectors that have come down. Certainly less than the negative, as a whole, but they still reflux blood. So, and what you see here is in microliters. I'm going to show you an illustration of what that microliter increment means in just a moment. But there is one connector that kind of stood out to me, because in the IFU it says it was 0 reflux. It was a neutral reflux connector and an anti-reflux connector. I'm like, my mind is blown right now. I'm like, how can this? I'm so confused by the definition, and I don't understand what they're trying to say here. Because in fact, this particular one, it refluxes on connection. So this is how I did the testing, and it drove me insane. I'm like, I can't believe that I've been told that neutral, by definition, and by what people have told me in the industry, needless neutral needleless connectors don't need to be clamped because they don't reflux blood. So I tested it myself. Not that I'm that big of a doubting Thomas, but I'm like, I am like so, blown away by my confusion and what I'm finding here. I need to do this for myself. And I did. What I did is I checked the reflux. I did 10 connectors, 3 tests on each connectors for a total of 13 connector devices, different devices, 390 tests. Bi-directional flow control. So this is a terminology, that they started talking about in the literature, and I'm like, I need to understand this because I don't think I understand this exactly, but I need to know more about it. So I also tested for bi-directional flow control. Basically, when you drop the bag down, does the blood come back up in the tubing? That's what the test was. This is not a real arm. This is a demonstration arm, a real, that you practice starting peripheral IVs on. On the right-hand side, you see this is a manometer, and you see 2 columns there. Some of the reflux was so tiny, I had to have a special calibrated tube that would measure that amount. And some of them were so much, I had to have a different tube that would measure the larger amounts. So that's what you see with me sitting there, connecting and disconnecting here. So this is what I found. There were only 2 of the connectors that I tested that had bi-directional flow control. And again, what that means is your bag goes dry, the pump stops, starts beeping. The patient, grabs the bag and holds it at their waist, and they walk to the bathroom. The blood backs up halfway up in the tubing. This ability of the connector will stop that very thing. And there were only 2, and it was the anti-reflux needleless connectors that did, in fact, have this bi-directional flow. So none of the positive connectors had this ability. None of the neutral connectors, and we knew none of the neutral and none of the negative. So the other 3 types did not have the ability to prevent that blood from backing up in the tubing when the pressure changes. So this is a demonstration. I'm going to play this video. So this is a bag. I'm just showing the drip chamber, but I'm lowering the bag to the level of the insertion site. On the left, you have a connector that does not have bidirectional flow control, and on the right, you have a connector that does in fact have bidirectional flow control. And you'll see the difference as we play this video. The bag is being lowered, and you see what happens. The blood backs up. It's an open conduit. Now, what you may say is, well, it's infusing. Well, yes, it is infusing, in fact, but there are times where the pump goes off, and people don't really understand how pumps work. If you've got 50 milliliters an hour, this is not a continuous stream that's spraying into the catheter. It's graduated. It'll infuse a few drops or a few microliters or a milliliter, and then stops. It's incremental. So every time that pump stops, then the pressure inside, may start to overpower the pump pressure and start to reflux blood up into the catheter. And here is what my results were of my study. It's a little busy, but once I explain this to you, it's very clear to see. Look up to the bars on the left side of this table, and when you read this, it's this is the amount of fluid movement that occurred upon disconnection. I took it one step further and identified reflux. So this in red. So reflux is in red. This is when the catheter is when the syringe is disconnected from the needleless connector. This is the amount of reflux that occurs. Okay, so you have 114 microliters, 39 microliters. The blue, that is actually positive displacement. So that's the pushing of fluid out of the catheter, and you can see that on both sides. Again, by definition, positive connectors, they reflux on connection. And when you look on the right side of this table, it says upon connection of syringe. And you look at the red on that side of that column, that's when those 4 connectors are going to reflux blood. So what you notice about this table is that every single connector reflux blood. The difference is when it refluxes and how much. So we need to know these things so that we better understand, our flushing techniques and flushing and clamping sequences in order to maximize or minimize, I should say, the amount of blood that's exposed to the catheter. If you look on the left side of the screen, that's a 22 gauge catheter. That portion of the catheter that's in the vein, the amount of blood that takes to fill that part of the lumen is just about 8 milliliters. So when you look back over to the chart, anything that has about 8 to 9, around 8 millimeters or 8 microliters will completely fill the lumen of that 22 gauge catheter. If the improper flushing is performed. So again, just looking from top to bottom, the top and in the red. So draw your eyes to the red bars on either side. That is the amount of blood reflux that occurs whenever you disconnect or connect each of these connectors. So what are the so how can we start to minimize reflux? And what do the standards say? Standards say, standardize your connector throughout your facility. Listen, I walked into an LTAC. I do have a small mobile vascular access team, and I went into this LTAC, and the patient had a triple lumen right upper arm PIC in, and they literally had 3 different type of needleless connectors on the same triple lumen catheter. There's 3 different types. Now, how does anybody expect the bedside nurse to know the proper flushing of that particular scenario? We need to standardize the connector throughout the whole facility. We need to also know the internal mechanism for the fluid displacement. We need to know when these connectors are refluxing blood. And for positive, it is on connection. So when you connect these, we certainly need to have it clamped to help mitigate the amount of reflux that will occur. And the exposure, because longer exposure times to blood, the internal internal surface of the catheter will attract more and more proteins and create more buildup on the inside. So we need to know what our clamping sequence is, and this is straight from the standards of practice. So if reflux and they tell you specifically about clamping, use the appropriate sequence. If reflux occurs during disconnection, clamp before disconnection. If reflux occurs during connection, clamp before connection. And for neutrals connectors, they simply don't exist. The terminology is outdated, and we have shown through multiple studies that there is no neutral displacement when you connect a needleless connector. It's either going to reflux on connection or it's going to reflux on disconnection. And another good practice is this: just keep the thing clamped when it's not in use. It doesn't matter. Doesn't matter what kind of connector you have. It just is good practice. And how do we mitigate this? We use positive pressure techniques, and so we want to make sure. I was taught, in nursing school almost 30 years ago. The positive pressure techniques. You're flushing and clamping at the same time, and then you disconnect. Now, and this is the technique I suggest that you use if you don't know. Like if you have no clue if it's a positive or a negative displacement, it's better to clamp while you're flushing and disconnect than risk, clamping after you disconnect and with a negative. You think it's positive, but it's actually negative, and you created this reflux. So if you don't know, that's the best way of doing it. The right thing to do is find out what kind of connectors that you have do the flushing and the clamping appropriately. And obviously, we need to use pulsatile flushing. This helps clear all the junk out of the connectors. A little bit more from the standards. It does say, follow the manufacturer's directions for flushing. However, whenever I went out and looked at the IFUs and the instructions, the instructions for use, some of them said follow what the standards of practice say. And I'm like, wait a minute. The standards say follow the manufacturer's directions, and the manufacturer says follow the standards. I'm like, I don't know what to do. So I was so thankful that the standards pulled out this, put this into the section with needleless connectors. In the absence of manufacturer directions, consider and report reflux volume for each type and use the following sequence. And here it is: negative displacement, positive displacement, 100% correct. However, I have an issue with this statement. Neutral and anti-reflux have no specific sequence required. Guys, we missed the mark on this. It is clear. Multiple studies show, benchtop testing, that neutral connectors reflux on disconnection. This is something that we need to be aware of. We need to understand, and I hope that this presentation and some of the publications out there are really going to pull this around. So this is straight from the standards of practice, and so I'm here to clarify this. Neutral, you can go out and look at these studies, and you can identify what connector you're using, and based on that, that's the type of clamping sequence we need to use. The one last thing that the standards of practice did acknowledge is anti-reflux has the least amount of anti-reflux connectors do in fact have the least amount of reflux. So that's an acknowledgement and whatnot. How does that play into fact? Listen, if your care and maintenance is pristine and you clamp when you're supposed to and you use pulsatile, is it going to make any difference what kind of connectors you use? I'm going to guess probably not. But my experience has been in the observations that I have made and some of the research that was done a decade ago with Lynn. We know that our care and maintenance can lack at the bedside. So I hope this was helpful to you guys. And I have just one final thought for you. This is my simple thought. If you want to eliminate internal thrombotic occlusions and decrease the risk of BSI associated with those declots, it's very simple. Keep blood out of the catheter. I'm Matt Gibson. I appreciate you guys, getting up early to be a part of this. And if you have any questions, I think we have some time.
Thanks, Matt. Great presentation. So this ends our CE portion of the session. Be sure to write down the code you see on the screen so you can get your CE credit for this. So Matt, you definitely sparked a little conversation going. So let's get the questions started. We have Laura. Does the body process fibrin naturally? Doesn't this also happen breaking off of fibrin when catheters are routinely removed?
My understanding of the question is that doesn't the body break down fibrin naturally, and what happens with the fibrin when the catheter is removed? Is that right?
Yes, sir. Yes.
Okay. So yes, the body does in fact break down fibrin naturally. And if anybody saw the thrombosis think tank, there were some pretty high percentages of the body breaking down thrombosis, not just fibrin, but actually a vein that has a thrombus in it. It certainly can take care of that. There are percentages of those that our body can manage. The problem is with vascular access devices, it just doesn't seem to get any better. So if it's sluggish or you have a withdrawal occlusion where you can flush it easily, and consistently, it's a persistent withdrawal occlusions, and you cannot pull that blood out of that catheter. It just won't get better. Now, what I think is that those fibrin tails perhaps is something that we actually just blow off the end of our catheter. And what happens to it? It goes into the lung. And the lung is a natural filter for blood clots. And it lyses the blood clots, and it will break down these products, or these sheaths of the fibrin, and all the goop that we squeegee off the catheter that when we remove the catheter, it's going to go into the lung, and the lung is going to take care of it. Hopefully, that's what seems to be happening, because it doesn't come out with the catheter. It's still there in the bloodstream. So yes, the body will take care of some of those problems.
So do you think goop scientific? I like it. That's me using Fluffy. That's awesome.
That's exactly right. Precisely.
So, fibrin forms as a response to foreign material. Can fibrin buildup be limited by material types or reflux control?
Interesting that someone brought that up, because the whole part of the presentation on the thrombosis think tank was about catheter materials. Polyurethane attracts fibrin and fibronectin like magnets. We have over 500 proteins in the blood, but those two particular ones just love polyurethane. It's just like a magnet. There is a biomaterial that it's a new catheter that has come out that shows some promise as to the adherence of fibrin to the catheter material. There's other coated catheters, other catheters that are engineered with polymers and other coatings that could and have some data that helps support the restriction of that fibrin and proteins adhering to the catheter. So to answer the question, I think material could, and design could impact occlusions.
Thanks, Matt. Here's a good one for you. Can you speak to valve picks that they don't have a clamp, and they obviously shouldn't be clamped, and then the use of various needleless connectors? It seems that we should absolutely use anti-reflux needleless connectors with these. Secondly, does a needleless connector compete with the valve inside the catheter?
This is a great question. And we don't have a study yet that I have seen that really studies this at all. I've used valve catheters in the past. And this is what I would suggest with valve catheters. I would start tracking my data as far as how often whatever valve catheter that you're using, how often it's starting to occlude, in the issues that you have. Uh, you know, um, I don't know the comparison between all of the valve catheters. Grashon, like a Grashon catheter that's a closed-ended catheter versus some of the other types of valves that we have out there. I haven't ever seen a comparison or a study that compares any of those, particularly with the outcome of catheter occlusion. So I can't speak in scientific terms or in actual data that says any one of those are better than the other. I don't, and I haven't ever studied, I don't, it doesn't work the same, if you have a hub to hub. So if you disconnect a catheter with a valve catheter with an open lumen, which you are not going to, it's not going to, it probably is not going to reflux blood, but we don't do that. We have needleless connectors on these. So I can't really speak to what is superior because I haven't ever seen any testing. Now, as far as using an anti-reflux with a valve catheter, I recommended this very scenario about 10 years ago. Well, it wasn't 10 years ago. It was about 5 to 6 years ago, and the facility was talking about having a lot of occlusions and wanted to know what the technology was that was the best. And I recommended an anti-reflux connector at that point in time. I didn't realize they had a valve catheter. And so whenever I went to the bedside, I was like, oh, well, we've got double protection here. So I know you definitely can use an anti-reflux valve with a valve catheter. How useful that is, I can't tell you if it's double protection or not. So for me, what I would do is I would look at the valve catheter and monitor my outcomes, and document what the occlusion rate were and the replacements were and whatnot, and then switch over to a non-valve with an anti-reflux connector and compare and go with what's the best. I would say the price point from an economic standpoint, the valve catheter is going to be probably substantially more money than dropping an anti-reflux connector. I don't really know those price points, but it's just something to consider.
Maybe that's your next project, Matt.
It could be. It certainly could be.
I know you like to dabble in that. So Deepan says, stellar presentation. What are some, but just switch for me. Gosh darn it. Now I need to go back and find him. Okay. What are some disadvantages of positive connectors other than splash during disconnection?
Well, so if you think about, I think about the ICU patient and the dipping of the candle in wax. If you connect over and over and over again, and you continually expose the inside of that catheter on connection to blood, it's possible that that's going to build up more, material inside of that catheter. If you're using a positive displacement connector, the best thing to do is when you connect, make sure that it's clamped. So when you clamp it and you connect it, it's going to prevent that reflux on connection from occurring. And then we use a positive pressure technique, which in reverse. So we're pushing on the syringe when we disconnect, and that's going to limit the exposure of that reflux blood. So it's going to be less exposure time. So to mitigate the reflux on a positive displacement connector, clamp. Make sure it's clamped when you connect. Flush, push on the syringe like you're trying to flush, then unclamp the connector, and that's the technique that will yield the least amount of blood exposure.
Thank you. Amy writes, when facilities are trying to optimize VAD performance and outcomes, they must understand and add-on device contributions. Most facilities use several and have not standardized, adding complexity. In your opinion, who is the primary stakeholder for these decisions?
The primary stakeholder for those decisions, in my opinion, is the patient, because they're the one that's going to be affected by the outcomes. Now the patient's going to not going to. It's not like they're going to go to a gift shop and say, "Oh, I'll take this needleless connector and this catheter and this." So they don't have that option. But the true stakeholder, is the patient for those outcomes. Now, from the hospital, having complications in vascular access are going to increase your cost. If you're not monitoring your complication, you have no idea what vascular access is costing you, either in occlusions or failures, whatever measures you want. But if your device isn't staying in from the beginning, from when you place it to the end of therapy, there's improvement to be made.
Thank you. All righty. Awesome presentation. Is there any reflux on positive flushing and clamping?
Is there any reflux on positive flushing and clamping? That
Correct.
is the technique that is going to mitigate and minimize the amount of reflux that you're going to have. So when you think of negative displacement and anti-reflux, even though anti-reflux is very, very, very minute, there is still honestly just a few drops of reflux that occurs. For those connectors that reflux on disconnection, the positive pressure clamping is absolutely a must. You clamp as you're flushing, and so yes, that is going to help. And then again, with the positive displacement, you do it just in reverse. So you make sure it's clamped and you're pushing on that syringe, as you unclamp.
Thanks, Matt. Will these devices prevent vacuum causing blood reflux from overpressurization when flushing, or using a syringe and placing forward force on the plunger and then releasing at the end of the flush or administration of the fluids?
Okay, ask me that one more time, because that was not a simple question.
Will these
One more
devices
time.
prevent the vacuum causing blood reflux from overpressurization when flushing, or using a syringe and placing the forward force on the plunger and then releasing at the end of the flush?
So I am a little bit confused by that. So if the vacuum pressure of disconnecting the syringe is what refluxes the blood. So the anti-reflux valve that's in there, the silicone dome-shaped valve, and they're all very similar. That does overcome the vacuum of the disconnect of the syringe. And as far as applying pressure, so you're applying the pressure and you're clamping at the same time, that pressure is going to support minimizing reflux. But that's why the clamp is important, especially with the negative displacement on disconnection, because you're applying that positive pressure to overcome the displacement that occurs with the disconnection. So I hope I answered that question, but it actually kind of confused me.
That was kind of a toughie. We'll thank Jim on that one. I'm going to give him one more here, because this is going to be our last question. This has been great, and we have so many really great questions, and I apologize we can't get to them all today. So I think we're going to reiterate one more time, because I do believe you answered this. What's the sequence for checking patency of a vascular access device lumen? Flush, then aspirate, or aspirate, then flush? And then what are the ramifications of
Technically,
those?
yeah, so technically, we should be aspirating prior to flushing because we want a blood return, so that's technically, but realistically, does that always occur? Sometimes, especially with central lines, that catheter might be up against the vein wall. It might be kind of turned in on itself and pushing into the vein wall. So a simple little, if you can't aspirate and you just give a little flush, it may move the tip just enough so it puts it back to the right place, and then you get blood without any problem. So the technical question or the technical answer, in my opinion, is that you would check a blood return prior to flushing. But we all know that there are certainly times where you're not getting a blood return and you do flush a few milliliters of saline, and then the blood pops right back. So there's a lot of theory on why that might be. There may be various reasons why that's happening. But the thing that we want to make sure of, especially with central lines, that we verify that patency. So before you give medication, especially a vesicant, then you do in fact, want that blood return. So having to, I would never just aspirate a line, not get blood return, and say that there is a huge problem, like we need to remove this catheter, or we need to use cath flow or whatnot. I would flush, and as most nurses are going to, or anyone that uses the devices, they're going to give a couple of milliliters. If I infiltrate 2 milliliters, somewhere other than the cavoatrial junction, 5 milliliters is not really going to do much damage. So I think it's a safe practice. It's just giving the medication. We got to get to that point. So a little bit of manipulation, a little fudging. I don't see that will hurt the patient.
Well, thank you. And everybody, thanks so much for joining us. Thanks for all the great questions. We have a short break right now. Grab your refill, short little bio break, and then meet me back here at 10:30 Eastern, 7:30 for me. And in Australia, I think you're in the middle of the night. But thanks so much. We'll see you in a few.